This is a video in clinical medicine from the New England Journal of Medicine.
Shoulder pain is one of the more common musculoskeletal symptoms for which patients see a primary care physician. Obtaining a focused history and performing a proper examination of the shoulder facilitates diagnosis and treatment. This video will review the anatomy of the shoulder, common shoulder injuries, and the procedures for obtaining the patient's history and performing a physical examination of the shoulder. A thorough understanding of the anatomy of the shoulder is crucial for a good clinical examination. The major anatomical landmarks of the shoulder include the clavicle, the acromion, the acromioclavicular or AC joint, the humerus, the subacromial space or bursa, the rotator cuff including the supraspinatus, infraspinatus, and teres minor posteriorly on the scapula, and the subscapularis on the anterior aspect of the scapula, the deltoid muscle, and the biceps tendon. Obtain a focused history. Ask the patient when the pain began, what makes the pain better or worse, whether it radiates, and how severe it is. Ask whether there are associated symptoms, whether the pain began after trauma or repetitive use, whether the pain is worse on overhead movements such as lifting or reaching for something, and whether the pain decreases with rest, exercise, or medication. Shoulder examination involves inspection, palpation, range of motion, and various special maneuvers. Fully expose the affected shoulder to permit visualization of anterior, posterior, and lateral aspects. Inspect the skin for ecchymosis or for rash and redness, which may suggest cellulitis. The presence of a scar may indicate previous trauma or surgery. Atrophy of the musculature may be the result of a chronic tear of the rotator cuff or of neurologic impairment. Finally, inspect the AC joint. If the clavicle is elevated, there may be an AC sprain, otherwise known as a shoulder separation. Palpate specific anatomical structures of the shoulder. Palpation may help you to identify the affected areas. Begin palpation of the sternoclavicular joint and assess for tenderness, deformity, or increased movement in the affected shoulder as compared with the unaffected shoulder. Continue to palpate from the proximal to the distal clavicle and pay particular attention to the AC joint and AC ligament. Acute tenderness in this region may represent an AC sprain or AC separation. In patients with a history of chronic pain, tenderness in this region suggests osteoarthritis. Next, palpate over the acromion and into the subacromial space. Tenderness in this region may suggest subacromial impingement or injury of the supraspinatus tendon. Subacromial impingement is caused by compression of the rotator cuff, the subacromial bursa, and other soft tissue structures between the humeral head and the undersurface of the acromion. Palpate the biceps tendon and the muscle in the bicipital groove. Tenderness may represent bicipital tendinopathy. Again, note any differences between the affected and unaffected shoulders. In bicipital tendinopathy, the patient may have tenderness in both shoulders. Pain may increase on palpation if bicipital tendinopathy is present. Evaluate the range of motion in forward flexion, abduction, external rotation, and internal rotation. If the patient has a full, active range of motion, there is no need to assess the passive range of motion. However, if the patient does not have full range of motion, then assistance should be provided. Loss of active and passive ranges of motion in all planes, especially in external rotation, is characteristic of adhesive capsulitis, but it may also represent advanced osteoarthritis of the glenohumeral joint. The sensation of pain on active abduction of the arm between 60 and 100 degrees away from the body may be associated with rotator cuff injury. Pain in this region during both active and passive abduction suggests subacromial bursitis. The muscles of the rotator cuff are the supraspinatus, infraspinatus, teres minor, and subscapularis. The supraspinatus muscle allows the arm to abduct. Test its function using the empty can test. Have the patient abduct the arms to 90 degrees with palms facing the floor. Then ask the patient to rotate the arms forward so the thumbs point downward, as if emptying a can of liquid. Now apply downward pressure on the arms and ask the patient to resist the pressure. Weakness in the affected shoulder as compared with the unaffected shoulder may indicate injury of the supraspinatus muscle, possibly caused by overuse, tendinopathy, or a tear. The infraspinatus and teres minor muscles each contribute to external rotation of the arm. These muscles can be tested simultaneously. Have the patient flex the arm to 90 degrees at the elbow, with the upper arm positioned at the patient's side. As you apply resistance, ask the patient to rotate the arm outward. Weakness in the affected shoulder may indicate a tear or tendinopathy in the infraspinatus or teres minor muscle. The subscapularis muscle internally rotates the shoulder. Test this muscle with the subscapularis lift-off test. Place the patient's hand on the patient's lower back and ask him or her to rotate the shoulder inward against resistance. It is important to stabilize the patient's elbow with your hand during this examination. Weakness or inability to lift the hand off the back may indicate a tear or tendinopathy in the subscapularis muscle. Inflammation of the subacromial bursa can lead to pain and limited range of motion, especially when the patient is performing overhead maneuvers. The Hawkins-Kennedy test is used to assess the subacromial bursa. Have the patient flex the elbow to 90 degrees, then elevate the shoulder to a 90-degree forward flex position, then internally rotate the arm. Pain with this maneuver may indicate subacromial impingement. An additional test for subacromial impingement is Neer's test, in which the clinician internally rotates the patient's arm and raises it. If the maneuver is painful, the test is positive and may indicate subacromial bursitis. The cross-body adduction test, also known as the crossover test, is used to evaluate the AC joint. Adduct the patient's arm across the body. Pain in the region of the AC joint may indicate sprain, separation, or osteoarthritis. The biceps muscle supinates and flexes the forearm. Inflammation of the long head of the biceps can cause anterior shoulder pain. Use Speed's test to assess the biceps by extending the patient's elbow and supinating the forearm, and then flexing the arm forward while applying opposing force. If the patient has pain with this maneuver, bicipital tendinopathy may be the cause. You can also perform Jurgensen's test to evaluate the biceps. Flex the patient's elbow to 90 degrees and supinate the forearm against resistance. Pain with this maneuver suggests bicipital tendinopathy. To test for anterior shoulder instability, place the patient in a supine position. Abduct the patient's arm to 90 degrees and then flex the elbow to 90 degrees. Apply pressure to externally rotate the shoulder further and note whether this maneuver induces a sense of instability or fear in the patient. Next, apply pressure over the shoulder in a posterior direction. If this force alleviates symptoms, then the relocation test was positive and constitutes another indication of shoulder instability. In a patient with suspected anterior shoulder instability, do this test gently and be careful not to dislocate the shoulder while performing the test. The rotator cuff is composed of 4 tendons: the supraspinatus tendon, which allows the arm to abduct, especially for the first 15 degrees, the infraspinatus and teres minor tendons, which allow the arm to rotate externally, and the subscapularis tendon, which allows the shoulder to rotate internally. Subacromial impingement of the rotator cuff tendons, the subacromial bursa, and other soft tissue structures between the greater tubercle of the humeral head and the lateral acromion is the most common cause of shoulder pain primary care clinicians see. Repetitive overhead motions such as painting or swimming most often induce this injury. To test for subacromial impingement, evaluate the range of motion and perform Neer's test and the Hawkins-Kennedy test. Rotator cuff injuries are common and can be assessed by testing the patient's strength against resistance during abduction and external and internal rotation. Osteoarthritis of the glenohumeral joint is caused by wearing of the hyaline cartilage of the glenoid, the humeral head, and the labrum. There is an increased risk of osteoarthritis in the glenohumeral joint if there is a history of a shoulder dislocation, a fracture, or a large rotator cuff tear. Osteoarthritis is characterized by progressively worsening pain during active and passive range of motion exercises. It can be tested by assessing the range of motion. Adhesive capsulitis, also known as frozen shoulder, is characterized by a painful, stiff shoulder and by loss of range of motion of the glenohumeral joint. Any injury or impairment that results in a decreased ability to use the shoulder can progress to adhesive capsulitis. Rotator cuff tendinopathy, as well as fractures and other conditions that result in immobilization, such as stroke, can precede adhesive capsulitis. The use of a sling and lack of exercise can also contribute to the development of this condition. To test for frozen shoulder, evaluate active and passive ranges of motion, especially external rotation. Painful, limited external rotation is a strong indication of adhesive capsulitis. Radiography is commonly used to evaluate possible adhesive capsulitis. In contrast to the findings in osteoarthritis, X-rays will be normal in adhesive capsulitis. There are several common pitfalls in the performance of the shoulder examination. Both shoulders must be viewed completely and simultaneously. A full view is necessary to make sure that deformities and asymmetries are not overlooked. Consider the possibility that shoulder pain may be referred pain from the neck. For example, cervical radiculopathy may present with shoulder pain and can be missed if cervical spine and neurologic examinations are not performed. Pain coming from the cervical spine generally localizes in the lateral neck and trapezius, whereas pain coming from the shoulder joint or rotator cuff commonly localizes at a lower point in the deltoid and the upper arm. Serious conditions such as shoulder dislocation and adhesive capsulitis can be overlooked if range of motion is not fully assessed. Thus, always test passive range of motion in a patient who has limited active range of motion. Obtaining a thorough history and performing a physical examination are the first steps in evaluating shoulder pain, allowing the clinician to form an accurate diagnosis. To confirm the diagnosis, it may be necessary to obtain radiographs, magnetic resonance imaging or MRI scans, or ultrasound images. Referrals to specialists may also be appropriate for diagnostic purposes or treatment.